Hi, I am Dr. Shashank Parekhji. I am working as a pediatric nephrologist at BJ Wadia Hospital for Children since 1991. This is my teacher and guide, Dr. Kumud Mehta. She has been in this field for time immemorial. She has been a guide to most of us, and she is the pioneer for pediatric nephrology for the city of Mumbai. Recently, she has been awarded by IPNA for the work that she has carried out over the years in India. Today we are going to discuss antenatal anomalies in the fetus for the ISPNCON 22 in association with Sir Reliance HN Hospital Foundation. I was just wondering, of late, don't you think we are seeing too many patients, mothers especially expectant, coming with their families with renal anomalies individually or as collective with other anomalies? Is this trend a recent trend, or that is because there has been more awareness amongst the sonologists and the obstetrician, or this has been there since quite some time, since you have been seeing it much more often?
Dr. Shashank, you know that I am in this business for last 40 years. I started when no sonography was there, and afterwards when the sonography came, it was used only for the welfare of the pregnant mother. Subsequently, details of the sonography were used to find out the fetus and later on the newborn, how they are doing, because of the curiosity of the mother and the family, and also all mothers wanted a perfect baby for them.
Yeah, and I think now the sonography has revolutionized the whole outlook, not only from the pregnancy point of view, even from the baby's welfare point of view, as you pointed out, ma'am. Everybody wants a perfect baby, and it's a little difficult, but at least we are there to help them out, where most of the times the outcome would not be as bad as what the parents have perceived it to be. Now the anomalies that normally one would see in the kidneys are as multiple levels. One would be positional abnormalities, which are generally very minor. The kidney is not in the renal fossa, it is just at an abnormally placed position, like in the pelvis or some other place, or it could just be a cross-fused ectopic kidney where the kidney is on the opposite side. Then the other thing would be the kidney is absent. It could just be a unilateral absent kidney, where I don't think it, one could expect a normal lifespan even with a normal other kidney being normal. It could be that the kidneys are absent bilaterally, which could always be a very fatal condition for the fetus. The other things that would be there, the size of the kidneys would be slightly abnormal, like it would be, one kidney would be slightly smaller or larger than what one would expect it to be. There could be associated hydronephrosis or hydroureter, either individually or as a combination of both, and this could be bilateral or unilateral, and according to that one would think of the causes that are likely possible, like it could be a PUJ obstruction, it could be a vesico-ureteric junction obstruction, it could be a simple PU valves, though not as simple as one would put it. It is probably one of the most complicated things that one is looking at. The other abnormalities that one could see are cysts in the kidney. It could just be a simple single cyst or multiple simple cysts, or it could be a multicystic dysplastic kidney, or it could be a polycystic kidney disease. The other things that one would see are abnormalities of the bladder. So it could be an exostrophy of the bladder, it could be an thickened bladder, it could be that the posterior urethra is dilated and causing trabeculations in the bladder. So all these abnormalities may be present collectively or in association with some other abnormalities in the fetus. Do you think, looking at this whole picture with so many abnormalities there, how often do we see them, and what is the more likely outcome in most of these cases, ma'am?
So what is important is, after gaining the information in a given child, it is our duty to counsel the parents along with the experts regarding what's going to happen to this child. If it is a minor, then all over the world the series say that some of these minor ones correct by themselves at the end of the pregnancy, and one doesn't have to worry about it. Yeah. While if there are other vital organs involved, like a brain or a spine and all, then it becomes a serious issue, but the issue is not with the kidney, it is with the other. So they require multi-systemic, consultation. The third group, I think, are where the obstetrician needs to be guided regarding the mode of the delivery and the immediate care of the newborn as well. And there comes what is known as productive and collective consultation. It's not only our duty to impart the knowledge, we must have a group where we all sit together first to decide what should be told to the couple who is eagerly waiting for our expert opinion. Don't you agree with that?
Yes, madam. And I think the whole collective group that is going to be sitting together would be probably the sonologist, the pediatric nephrologist, the obstetrician, and the intensivist or the neonatologist who is going to be looking after the child once the child is born. I think that would make more sense, ma'am.
Sure.
Absolutely. Yeah. And what would be our this to mention on follow-up studies? How often should we tell the parents or the obstetrician to get a scan done, and what according to you should one be looking for in the regular follow-up scans that are going to happen successively, ma'am?
Yeah, actually the obstetricians and I think the legal Society of Gynec Obstetric has put it down. The first scan should be done at 16 weeks, where almost all the organs show whether they are normal or abnormal. The second scan needs to be repeated for those children where the first scan has shown abnormality. The same should be. Suppose there are worsening of the sort of the previous whatever scan is, like a so as you mentioned earlier, any of these like AP diameter, texture of the kidney, as well as the thickness of the parenchyma, that shows that the kidneys are now need to be very critically evaluated. I think the second scan should be repeated after 4 to 6 weeks of the last scan, and by the time the child or the pregnancy increases to 20 weeks, beyond that whatever scan needs to be done has to be just before the child is delivered.
Madam, I am of the opinion that once we have a particular abnormality, especially if it is a very severe abnormality, I would say probably get a scan with another sonologist once to reconfirm that we are dealing with the same thing, so everybody is on the same page, than having going by one particular person's judgment, and sometimes things don't work out that way, and then we might be in a medical legal soup. Wouldn't you agree with that, ma'am?
Very important point. Sharing the responsibility is the key to this consultation, which is called a productive
Nothing wrong with being reconfirming what we are seeing. And probably the sonologist has to look for multiple things on successive scans. Okay, once we have confirmed that there is an anomaly, over a period of time, once the anomaly is there, how do you monitor that on the successive scans? So probably you would be repeating the scan maybe 4 weeks, 6 weeks or 8 weeks down the line if the abnormality is very mild. Especially now the commonest thing that we see is little fullness of the pelvis. The pelvic diameter is a little on the higher side. Now how would you monitor these patients? How often would you do the scan, ma'am?
Yeah, actually I think it's a good idea, the 3 scans which have been said. Minimum 3 scans, as I said, 16 to 20 weeks, and after that another 10 weeks if it's a serious condition. That means any of the abnormalities mentioned have worsened, and then the appropriate treatment has to be started from there only. So there is no question. Then it is a specialist, that is a pediatric nephrologist, and if required even the surgeon's opinion has to be taken, like posterior urethral valve and all. So that's an entirely a specialty, what is called reference has to be, and that many of the couples and their parents don't understand, and that is what is going to make a difference in the ultimate outcome of this
fetus. True, ma'am.
Yeah.
Is there any role for early intervention, as in utero for certain conditions, or would you not recommend it just now, ma'am?
Actually, I went through a lot of literature before this, and we found that those who are promoting the intervention, they are also disappointed. And they have stopped doing it, and they have stopped claiming success.
So probably in our country anyway, it is in a very nascent stage, and overall world over, the outcome is not very encouraging at present. Okay, let's put it another aspect to the same thing. Would you recommend early delivery in certain cases, ma'am? Especially, just to give you an example, there is a child where the pelvic diameter has been increasing progressively and the cortex has started getting thinned out compared to what it was earlier on the successive scans. So, and these days, you know, with the tertiary level care that has been there, it is very easy to manage a 33 or 34 weeker child. So, keeping the child inside the uterus probably may be more damaging to the kidney. Getting the child out would maybe be a better option, especially from protecting the kidney, and the survival chances are better. But probably that would be, I think, in conjunction with the family decision, the urologist, the intensivist, and us together, I guess, with the obstetrician on board along. So everybody should probably be on the same page. But would you recommend something like this in certain conditions?
Yeah, we would very strongly recommend that this child is salvageable if taken good care by the specialist. We can't insist that you
no,
send
we will
to
not be insisting, I guess so. We can just guide them. I think we are there. They have come to us for guidance.
And we have treated so many of them and they have done very well. So we can, usually I give them the phone numbers of the children who have benefited and the parents, because whatever we say, it has to be endorsed, and that has worked better. So we sort of guide them, but we cannot make the final decision. It is ultimately the family.
One more question. At around 16-18 weeks, would there be any indication for termination of pregnancy? Any particular condition that you would say would be an indication for termination?
I only say that the termination may be considered if associated with that there is a neurological disorder which has no chance,
or probably severe multiple anomalies that are there,
severe multiple cardiac,
or otherwise we are dealing with something like Potter syndrome where there is bilateral renal agenesis. It doesn't make sense to carry on with the pregnancy. The child is already developing hydrops. I don't think it makes any sense to continue. Of course, finally that decision also probably has to be taken by the parents. It is their decision, but probably these become very clear-cut indications to recommend it, I guess.
I plainly tell them, if this child was born in my family, I would definitely, sort of tell the couple. So, if that sends the strong message, that's all that I want.
Finally it's up to the parents then, I guess.
Of course.
So, overall at the end of the day, ma'am, what do you think would be the take-home messages for the parents from this whole picture, ma'am?
I would say that minor type of sort of anomalies which happens in almost 1 to 5% of the normal pregnancies. One should not do anything, just repeat if at all. If they have no faith in the first one, then send to somebody else who is equally competent, so that they are assured that it is normal. And then if they want to keep on doing, because ultrasonography is one of the safest sort of that there is no radiation or there is no harm done to the pregnant mother or the fetus. But I wouldn't recommend that. Once it is done, it is done. And subsequently, if they find in the second scan and the third scan, which we already said, second scan is most important. And if they find something which is not picked up in the first scan, then you take on that. So it is entirely, I think, a different kind of a science where a lot of expertise from different specialists is required. So ultimately, as we said, multiple consultations need to be done to find out which is the best solution for this unborn child and to reassure the family.
So probably, just to sum it up, I would put it that way: if an individual has got one-sided disease, in all probability the child could have a normal lifespan. So that is the first thing that we need to allay the fear of the whole family, that one kidney is normal, you are most likely to have a normal lifespan with a kidney. Don't get worried or hassled, and it is not an indication to do anything in haste. Would you agree, ma'am?
Yeah, sure.
Absolutely. Another thing would be that confirm with the second sonography, especially if your first one is showing a particular thing, from another expert sonologist, to be 100% sure that we are all on the same page. Third probably would be, these children would require long-term follow-up. So we need to express to the parents that it is not only now, but once the child is born, probably you may require in certain conditions long-term follow-up. Probably the fourth thing would be to think about early intervention in only certain individuals where you would probably bring the child out earlier than required, but that is going to be a collective decision and a productive consultation of all those who are on board. But the final decision on this also should be taken by the parents and their family, I guess. And overall, one should explain, I think, the finances that are going to be involved, because madam,
very important.
long term kidney diseases most of the times can drag on to long term at times, and they can be very draining to an lower middle class or a lower class family over a period of time, ma'am.
No, I think we should also give them avenues from where they can collect the
True,
money. I
ma'am.
mean, ultimately, it's our duty to see that this child and his family needs our guidance throughout.
Yes, ma'am.
And we have done it in the past.
Yes, madam, I know that. So that is, I think, overall picture that one would, but I don't think the picture is very bleak overall.
Not
It's
at
only
all.
in certain conditions where the picture can be a little difficult, but most of the times I think the child would do well. And so we should actually try and make the parents and the mother more comfortable, so that the pregnancy becomes a little more joyous than being more anxious. Probably. Yeah, that's
true.
That is what we want them to be, actually, right?
Yeah, I feel very happy when somebody meets me socially and say, "You are Kumud Mehta? Oh, you know, I'm so and so, and you helped my parents to look after me." And I said, "How old were you?" I don't remember. I must have been 5 or 6 years, but I was born with a defect, and look at me now.
True, ma'am. So
that's the award we want.
Yes, madam. I think that's the most important thing.
Yeah, and there are any numbers, and that's exactly the purpose of getting into pediatric nephrology.